Good afternoon, this is Mrs. Terry, and I am going to do a quick video on chapter 22 and hopefully 23, which is part of your Unit 4 Health Science Studies. So if you will go to chapter 22 and look at your PowerPoint, and we will begin. You need to know the anatomy and physiology of the respiratory system. Of course, you have the upper and lower respiratory tract. And if you follow along in your book on, let's see, page 404 right now, you have the organs, which are located outside the chest: the nose, nasal cavities, pharynx, larynx, upper trachea. And then the lower respiratory tract are the organs located inside the chest. So that's the trachea, the bronchi, bronchioli, alveoli, and the pleural membranes, and the chest cavity muscles, which you see here, that's the diaphragm. The nose and nasal cavities consist of the nasal septum, the nares, the nostrils, and these conduct air to the lower respiratory tract. The pharynx, which is the nasopharynx, the oral pharynx, and the laryngopharynx. The larynx, which is the thyroid cartilage, or what we sometimes call the Adam's apple, and the vocal cords. The trachea, it divides into the right and left bronchi, and it is cartilaginous rings, and this is so that it can support and keep the trachea from collapsing. So it's little rings that are in the trachea that keep it up there. The paranasal sinuses drain into the nasal cavities, and if those get infected, of course, you know, we have sinus infection, a lot of drainage. The oral pharynx and laryngopharynx are part of both the digestive and respiratory systems. The pharynx also contains the opening to the tonsils and the eustachian tubes. And of course, the eustachian tubes are known for causing these ear infections, otitis media. And the thyroid cartilage we've talked about and will again is the Adam's apple, and can be seen when we swallow. So that's your larynx. You're seeing that thyroid cartilage there. That's the Adam's apple. The nose and nasal passages, the functions are to warm, moisturize, and conduct air. The pharynx, or the throat, conducts air to the lower structures. The larynx, which is our voice box, has our vocal cords. It vibrates the vocal cords, produces sound, and conducts air to the lower structures. And the trachea is the what we call our windpipe, and it conducts air to the right bronchus and left bronchus. And these are diagrams of all of that. You need to know you need to know where all of these are. Like, you need to know where the epiglottis is, where the vocal cords are. The thyroid gland is located here. Here's the esophagus, and then the oral cavities, eustachian tube, etc. And I have seen this when you're intubating a patient. The vocal cords look exactly like this. It's an amazing thing to see. And when someone is being intubated and put on a breathing tube, the pulmonologist inserts the tube right between these vocal cords. It's really quite amazing. And here's those cartilaginous we were talking about that keeps the trachea from collapsing. The epiglottis has a very important function. It acts, let's see if I can go back. So you find the epiglottis, here it is right here, okay? It has a real important function. It's a flap that covers the opening of the trachea or the glottis. So like during swallowing, it closes so that food does not enter the lungs, and instead it enters the esophagus and then goes into the stomach. And in the elderly population, that flap becomes weakened, and you'll hear they talk about the elderly aspirating water or liquids or whatever. That's because that flap has gotten weak over age, and they're more likely to aspirate fluids. So that's why you have to be real careful. I'm going to let you read about the Heimlich maneuver and watch this. I think you all know what that is, and it's how you prevent someone from choking. The lower respiratory system is the bronchi, the bronchioles, the alveoli, and oxygen diffuses from the alveoli into the blood. These are the little alveoli that are inside of the lungs. And the pleura, that is a serous membrane that lines the outside of the lung and the inside of the chest wall. And I think that is on your blueprint. Talks about pleural membranes, and that's the visceral and parietal pleura. And you need to know this, and that's the serous membranes that line the lung. The visceral is the outer surface of the lung, and the parietal pleura lines the chest wall. You need to find that in your textbook and understand where that is. Be sure and read your notes that are in the bottom part of the PowerPoints. We've talked about that before. When you go to the slideshow, make sure you say show notes so that you can read all that. The bronchial tree is the right and left bronchi and has these rings we've talked about, and carina. The bronchioles are smooth muscle, and the alveoli are single layered membrane. The functions, the bronchi conduct, and you need to know this page, the bronchi conduct air to the bronchioles. The bronchioles are smooth muscle that determines the diameter, and they regulate airflow to the alveoli. The alveoli are small grape-like structures, or air sacs, and they exchange oxygen and carbon dioxide with blood in the pulmonary circulation. So the alveoli are very, very important, and that is demonstrated in figure 22.3. And you will see the clusters that are inside of the alveolar sacs, and how they are formed inside the lung. But the alveoli is what exchanges the carbon dioxide and the oxygen. And the word emphysema refers to puffed up alveoli. In other words, when someone has emphysema, that is enlarged, and that is why they can't exchange oxygen and carbon dioxide well, and why they're short of breath and they have to be on oxygen. That ability to exchange oxygen and CO2 is gone. Oxygen moves from the alveoli into the pulmonary capillaries, or into the blood, and carbon dioxide moves from the pulmonary capillaries into the alveoli. 70% is carried through the blood in the form of bicarbonate. So CO2 forms bicarbonate and is carried through the blood. And oxygen goes into the pulmonary capillaries. There's so many alveoli that their collective surface area is about the size of a third of a tennis court in an adult. This favors gas exchange. Any condition that decreases the number of alveoli decreases gas exchange. Kind of makes sense. And it decreases that ability of diffusing oxygen and carbon dioxide. atelectasis refers to collapsed and airless alveoli. Patients with atelectasis will usually need a chest tube. This is why, as nurses, we instruct our patients to deep breathe after surgery. And so that atelectasis is like collapsed alveoli. And without that, you cannot exchange the gases. So it's an emergency, and if they've been in a car wreck or fallen and collapsed a lung or whatever, then you have to have a chest tube. And if patients do not deep breathe and cough after surgery or after being in bed for a long time, then over time, and it doesn't take long, then they will potentially develop atelectasis. And the fluid and all gathers in the bottom of their lungs. They develop pneumonia, and it leads to atelectasis. So very important for us as nurses to know. Lungs are large, soft, cone-shaped organs, and they contain what we've talked about, the structures of the respiratory tract. There's the apex, which is the top, and the base, which is the bottom. The right lung has 3 lobes, and the left lung has 2 lobes. The parietal pleura is the outer serous membrane. We talked about that. The visceral pleura lines the outside of the lung. So you'll see the parietal is out here. It's a serous membrane on the outside, and the visceral lines the outside of the lung. The visceral and parietal pleura are attracted to each other like 2 flat plates of glass whose surfaces are wet. You know how you can put water in between 2 surfaces like that, and how they slide, but they have resistance also. And that's what these 2 pleura act like. And then there's a space in between called the intrapleural space. And that is made up of serous fluid, and you can get what they call pleural effusion. And pleural effusion is an infection, causes extreme pain because that surface is tense. And when it rubs against one another, it causes a lot of pain. And it's from excess secretion of pleural fluid. And that's a pleural effusion. Then you get pus, and it's called empyema. And that patient will probably be in ICU more than likely. They'll have a chest tube also. But you need to understand what the visceral and parietal pleura are, and where they are. And on the summit up, air moves through the following structures, from the nasal cavities to the pharynx to the larynx to the trachea to the bronchi, bronchioles, and finally to the alveoli. So please understand that. When the air reaches the alveoli, and remember the tiny grape-like sacs at the end of the bronchial tree, the respiratory gases, oxygen and carbon dioxide, then diffuse across the alveolar pulmonary capillary membrane. Most of the respiratory structures conduct air to and from the alveoli into the lungs. Only the alveoli function in the exchange of gases. So that's where the gases exchange, carbon dioxide and oxygen. The lungs contain the structures of the lower respiratory tract. Pleural membranes surround the lung and line the thoracic cavity, creating the intrapleural space or pleural cavity. And all of that is what we just read about. And there are some diagrams of how by blowing up a balloon you can understand all of that movement and recoil and surface tension and the effect of surfactants on the lungs, which cause the lungs to inhale. Surfactant is one of the terms that you need to know. Those are there are cells that secrete surfactant that when you're carrying a baby, Surfactant only shows up towards the end of fetal development. And so if a baby is born 2 or 3 months prematurely, they don't have enough surfactant. And as a result, surface tension with the alveoli is excessively high, and the alveoli then collapse, and the infant is in respiratory distress. And this is called respiratory distress syndrome for a baby, and it's an emergency. So when the babies are born premature, nowadays, they give them surfactant, and that helps their little lungs get stronger because they don't have surfactant when the mama is carrying them that early, if she delivers that early. And so that's just one of the wonderful things that we've learned in medicine that helps these premature babies. So lung expansion, it depends on two forces, recoil and surface tension. And one factor that promotes lung expansion is negative intrapleural tension, negative intrapleural pressure. And this is what I was talking about with surfactant and elastic tissues. Water has high surface tension, and surfactants decrease that surface tension. So normal lung expansion, negative intrapleural pressure allows the lung to expand. And this is very important for you to know. It overcomes elastic recoil and surface tension. We'll talk about that a little bit later. And here is loss of negative intrapleural pressure and the lung collapses, what I was talking about. If they are in a car wreck or whatever, and this intrapleural pressure collapses, then they can't breathe sufficiently, and that it has to be restored. And this is done with chest tubes, and what I told you was called atelectasis, and that is caused when there's a collection of mucus in the lower part of the lungs, usually after surgery or whatever, and patients can come in and develop atelectasis. And you don't want that to happen. So, as I told you, you deep breathe, cough, deep breathe. So, here's an example of a knife wound, a ruptured, what they call a bleb. And a bleb is just what I say, one of those things that happens. Sometimes patients can be just doing nothing and they get a bleb, and it just causes their lung to collapse. Either they cough too hard, or they just have a weakness in that area of their lung, or whatever. And so they may come in and have what they call a bleb. And again, they would need a chest tube. Compliance is a measure of elastic recoil. When compliance decreases, lungs are more difficult to inflate. So if a patient has pulmonary edema meaning swelling in the lungs, and usually there's congestion with pulmonary, not usually, but there is congestion with pulmonary edema, then that causes the lungs to be difficult to inflate. Respiratory distress syndrome, we talked about that with babies, but adults can certainly have that. Pulmonary fibrosis, a certain part of the population have fibrosis. I had a very good friend that had that, and he got a lung transplant. So their lungs become thick with fibrosis, and they can't inflate and deflate their lungs correctly. So all of these cause recoil to be less. And if lungs are too stretchy and they cannot expel the air, and you see that a lot on emphysema, and they can't exhale, then they can get what we call a barrel chest. And you would see patients with a barrel chest. Okay, so you need to know Boyle's Law, and I wanted to read that to you. So Boyle's law is related to ventilation, and which is the breathing in and out of air into your lungs. Okay, so when you inhale, your thoracic cage moves up and out. So as you're listening to me do this, y'all take a big inhaled breath. You feel everything. You feel the volume in your lung, your thoracic cavity in your lungs get bigger. The volume is bigger. When you breathe in, you can feel it get bigger. And as the volume in the lung increases, the pressure in the lung decreases. So there's less pressure in the lung when there's more room in the lung. That's about the best way I know to describe it. As a result, air flows from a higher pressure to a lower pressure from the nose into the lungs. So that's how we inhale. Okay? So the pressure, the volume in the lung increases and the pressure in the lung decreases. So it goes from a higher pressure to a lower pressure, and that's how the air goes into the lung. And exhalation, do the same thing. When you exhale, then the lung volume decreases and the pressure increases. And so therefore the air flows out of the lung. Okay? Air flows in response to pressure changes. And the pressure has to do with the volume. Inhalation is associated with an increase in thoracic volume. Exhalation is associated with a decrease in thoracic volume. So it takes a little bit of thinking about it, but when you get that down in your head, read about Boyle's law, and you'll understand. And always think about it as it relates to pressure and volume. Okay, and you'll understand then how breathing, inhalation and exhalation then occurs. Okay. And also know the diaphragm is the chief muscle of inhalation. So as that diaphragm moves up and down, then that is how we control the volume in our lungs. And people who are very large, who get short of breath, just think about that. Their weight is pushing that diaphragm up, and I say squashing their lungs, but they're pushing that diaphragm and causing less and less volume ability in the lungs, and therefore people are short of breath. So you have 3 steps in respiration: ventilation, which is inhalation, exhalation, we've already just talked about, and then the cycle. And so the respiratory cycle is one inhalation and 1 exhalation. That's simple. Exchange of oxygen, CO2, is in the lungs at the alveoli and at the tissue level. And the transport of those two are by the blood. And I will let you read all that. So ventilation, we talked about, we inhale, the diaphragm and intercostal muscles contract and oxygen moves in. Exhalation, they relax and carbon dioxide moves out. The diaphragm is, I told you, the chief muscle of inhalation. And I talked about Boyle's law, and you need to know that. It has to do with volume and pressure. And here is where we've talked about what I just was describing. The diaphragm is innervated, or what makes it do what it does, that's what innervated is, by the phrenic nerve. And I don't know, when I was in nursing school, that is one thing I got stuck in my head and I've never forgotten it. The diaphragm is innervated by the phrenic nerve. So I challenge you to always remember that. And when you hear phrenic nerve, you're going to think of me someday. But the diaphragm is innervated by the phrenic nerve. That is the major peripheral nerve that's involved with breathing, and that's your blueprint item number 1. The intercostal muscles are innervated by the intercostal nerves. Respiratory muscles are skeleton muscles. You need to know all of this. The motor nerve supplies the respiratory muscles. Supplying the respiratory muscles are the phrenic nerves. And they come from the spinal cord. We've talked a little bit about oxygen and carbon dioxide. Lungs are good because there's large surface areas in the lung. The alveoli are thin and can exchange that oxygen across the capillary walls. Oxygen moves into the blood from the alveoli, and CO2 moves from the alveoli into the alveoli from the blood. So that's how it circulates through your lungs. The amount of each gas expressed as partial pressure, so the PO2 and the PCO2, almost 98% of our oxygen is transported by what they call oxyhemoglobin. You need to know that for the rest of your life. Oxyhemoglobin. It transports the oxygen across the red blood cells. So our red blood cells carry 98% of our oxygen. And carbon dioxide, and we'll talk about more of that in pharmacy, but 70% is transported as bicarbonate. Remember the unit 1 talking about hydrogen combining with CO2? So it becomes bicarbonate. 20% is carbohemoglobin, and 10% is dissolved in the blood. But you don't necessarily need to know this, but you do need to know, in essence, what I don't care about the 70 and 20 and 10, but you need to know oxyhemoglobin carries in the red blood cells the oxygen, and CO2 becomes bicarbonate. We talk about tidal volume, inspiratory reserve, expiratory reserve, and residual. You'll hear more about that, how much tidal volume. Normal quiet breathing has a range, and inspiratory and residual, especially if you're working where a patient is on a ventilator, you go to ICU, patient's on a ventilator, you're going to talk about vital capacity, tidal volume, total lung capacity, etc. Some air never reaches the alveoli, and that's called dead space. It's not available for gas. It occupies anatomical dead space. And again, we need to breathe deeper. If this voiceover stops, I think it runs 30 minutes, I'll continue it on another. The medulla oblongata is the main control center for breathing. You have to know that. It controls our respiratory control center. So people that have brain injuries, many times, that's why they're on ventilators, because their medulla oblongata is injured. The PONS can cause you to not breathe at all. And there's chemoreceptors in the brain from the central nervous system to the peripheral, and they can detect changes in the blood and carbon dioxide. So neuro controls breathing, and here's the PONS, here's the medulla oblongata, etc. Voluntary emotions can cause our rate and rhythm to increase or decrease if we're crying or if we're hysterical or if we're running or whatever. And involuntary are the chemoreceptors in the brain. I want you to know these terms. Apnea means you're not breathing. Chain stoking, we'll learn more about that, but that's where you're at end of life and you're breathing rapidly and then very slowly. Cyanosis, you don't have enough oxygen. Dyspnea, you're having trouble. Hyperventilation, you know those. Hypoxia, there's not enough oxygen. Kushmal, we'll have some homework on that maybe in pharmacy. Rales, rhonchi, I'm sure you're studying about that in your assessment. and stridors, that high pitch that babies make when they have bronchitis. Tachypnea is breathing really fast. You need to know all of those. And so that is chapter 22.